Are we ready, Eric?
Yeah, I think we're ready to go.
Dr. Tobis announced that he was coming. Is he there?
I look and see. Hang on. And he's not here yet.
Why don't we make a little change and start with the last?
We will avail him. We can make available for him the recording.
All right. I was trying to take a little more time by adding a case that is besides the coronary aneurysm at the beginning, so we can spend more time with him if he comes with the main subject of coronary aneurysms and ischemic manifestations in Kawasaki. Do you think Dr. Mladen Vidovic is coming? No.
Muted.
There were two people there announced that they were coming to this meeting. One from Seattle, I don't remember the name, but is with Dr. Sattler. You don't know of any. Can I continue or nobody's there?
So I see it's just us right now.
So this is the case I would like to discuss with you, Eric, if you have a view of this. This is a case of a 41-year-old female that came from out of town.
Muted.
With a diagnosis of myocardial bridge of the left anterior descending that was described by CAT scan angiography as being a long segment of intramural course in the context of a history of a severe chest pain that started in February 2013. And since then, it was an emergency room initially to rule out an acute myocardial infarction. They ruled it out by enzymes and by EKG evolution. But she had minor T-weight changes and nothing else. So she was tried on medical treatment without firm diagnosis. But eventually they did a CAT scan angiography because the pains continue. And it was an atypical chest pain that comes both at rest and with exercise. It's relieved by rest when it's on, with exercise and by nitroglycerin when it's at rest. It's in the right location. It comes in the upper substernal area and goes to the jaws and to the left arm. And it was quite suggestive of sort of an in-between prince metal angina or spontaneous spasm. And they did a cardiac coronary angiogram with CAT scan angiography. They showed this intramyocardial LAD in a CD that we have seen. We found that actually there were several arteries that were intramyocardial, specifically pretty deep in the obtuse marginal branch there was intramyocardial. So it was not clear what the diagnosis was and if it was or not a myocardial bridge to cause the symptoms. So we decided to do an angiogram, and as clinically there was evidence of spasm, to do an acetylcholine test if the diagnosis was not obvious. In general, we never sent anybody for surgery with a myocardial bridge unless there is evidence of spasm. The stress test was negative, but with chest pain. So this is a coronary angiogram that was shown in a fixed image after acetylcholine and after nitroglycerin. In the left is the one after acetylcholine, and you will see that left anterior descending here is basically a posterior anterior view, as all the septals. As usual, the left anterior descending is this one that crosses here, and it goes to the apex. It's obviously a large for territory branch, but extremely small, almost completely occluded. This is not the continuation of this one, but it's a continuation of this one, LAD definitely. And this is the same artery, this one, that we'll see in motion in a few seconds. That is the proper LAD after nitroglycerin. This test with acetylcholine 100 micrograms and at 52 caused EKG changes, chest pain, and immediately was relieved by intracoronary nitroglycerin. So basically what we see, and we'll discuss it after we show the motion picture, is that there is a severe abnormal response to acetylcholine, evidence or suggestion of coronary spontaneous spasm that disappears with nitroglycerin. Here comes the picture in motion. This is so short. I know. So here is the right anterior oblique projection. At baseline, pretty normal. You see what the LAD is this one. And there is superimposition of vessels. You go by the septum, the origin of the septum. If you look at the end of this picture, there is something that is strange up here. There seems to be a collateral, but it's not clearly related, but it tends to join the obtuse marginal tree, a third vessel from the circumflex. But it's a question if it is or not an occlusion by an event of obstruction by some sort of mechanism that we don't understand. There is no calcium, low risk for coronary disease, very aggressive, very intense executive in a firm that she acquired with a group and eventually is running as a general manager. So this is another projection in a little cranial right anterior oblique. We are looking for the myocardial bridge angiographically, and this is one of the points of the presentation. Definite intramural course of the coronary arteries may or may not manifest angiographically as systolic compression. In this case, there is no branch that shows systolic compression of blanching. You would expect this to be the affected section. There is a little kinking, but nothing obstructed. We'll show it in another view. Here too, nothing obstructed. Another. Next. Also here, there is some kinking that accentuates with systole, but nothing obstructed. It doesn't look to be related to intramyocardial course. The obtuse margin also doesn't look to be showing any systolic compression. Next. This is the best picture to show the left anterior descending, and it's a good view. It's a cranial PA projection, and it doesn't look at the myocardial branches. So we proceeded to a acetylcholine test. Let's go to the one. With 50, she had the same result as with 100. Okay, this is 100 next. As you see, the distal LAD, the one that we showed in the frozen picture before, is the one here. It's almost completely occluded. She had chest pain at this time and EKG T changes. But she has to give the antidote because she had severe pain. You see this lesion or this distal artery, this could be an artery that originally was connected to the obtuse marginal, like an occluded vessel. And the reason to discuss it is especially because there is some hypokinesia at that level, and we'll see it in the next pictures after nitroglycerin injection. This is at the same time under the effect of acetylcholine, a severe narrowing diffusely of the distal LAD. Next. Nitroglycerin is given now, and it shows a perfectly opening of the LAD. This one with the curve. It's all perfectly open. Definitely, this is abnormal behavior, suggesting endothelial dysfunction, at least in the territory of the left anterior descending. You see the vessel that we don't know if it is a total occlusion with the collateral circulation is down here. Eric, if you want to comment, you go ahead at any time. I'll show you the ventricle. Is this a new fellow joining? So the study concludes that there is a spasm under the effect of acetylcholine that disappears after nitroglycerin, and the vessel that could have been occluded but not definite. Next. This is the left ventricular angiogram. It doesn't show a perfectly normal ventricle. It's mild, but there is an obtuse marginal territory hypokinesia. Nothing serious, but it could be that the prolonged chest pain that brought her to the emergency room was actually this vessel that occluded for some reason. As we mentioned in the past, a severe spasm that lasts for more than 20-30 minutes can lead to permanent occlusion by clotting. So it could be that she had indeed something at the level of the obtuse margin that is intramyocardial by CAT scan. Unfortunately, we cannot show you the CAT scan next, especially the cuts that are significant to show this is the tail of the intramyocardial, but our cardiac radiologist, Dr. Chang, had no doubts in recognizing intramural. So in conclusion, we identify a patient in the age where spasm is more frequent than coronary arterial sclerosis, with the history, there is support to the idea of Prince metal angina of some kind, where myocardial bridge could have been a predisposing factor, but we could not see it by angiography, but it can be seen definitely by CAT scan angiography in the separate study.
Paolo, can you hear me?
Yes, how are you, Jonathan?
Oh, good, Paolo. I was wondering, does this patient have any migraine headaches?
No. Do you have any questions that it goes together?
Well, I've seen some patients with severe migraines who also have chest pain and some spasm. And I'm not sure if there's a connection, but I think in some of these people there might be. And then the other thing, I've seen a few people who have a patent foramen ovale and coronary spasm, and then we close their PFO and the chest pain goes away. And one of these patients had a ventricular fibrillation in the emergency room when she had an episode of chest pain.
And you think that it could be a paradoxic embolization or spasm?
No, I think it's spasm, but it could be some chemical that goes across, maybe serotonin, or I don't know what other chemical could be, that otherwise gets metabolized in the lungs, but that if it gets across could cause spasm.
Yeah, it's interesting that you bring this subject because I saw a patient with that connection, a PFO and chest pain and migraine headache, and I told him that probably there was no connection, but we'll see and treat medically initially. But it could be that this is a syndrome. I don't know that it's likely that in that case there was a left to right. It was more a small ASD than a patent foramen ovale. It was cut from the left to right, so it was quite unlikely there would be paradoxic embolization or flow from the right to the left. But it is interesting.
Actually, with ASDs, all you have to do is strain, and you get an intermittent right to left shunting. And it's reported that about 5% of ASDs have paradoxical emboli.
It could be, but it would be.
So you can get this. You can get this either with an ASD or PFO. PFO, most of the time, the shunt is left to right, but it's only when you strain that you reverse it and it goes right to left.
But it's quite unusual with an ASD with significant flow to have migraine headache and an indication for intervention in that context with a large or moderate size.
Right. If there's a large ASD, large flow left to right, then it's less likely. But you can get intermittent. You can reverse the flow.
Very good. So let's pass to the other subject. If we're all in agreement that there's no more. Eric, do you have any idea about the branch of the obtuse marginal? Do you think it's possible that it was a total occlusion or is a subendo? I suggested that the rest of the fellows that were seeing these movies that was a subendocardial network. At times it's seen, but it's not necessarily atherosclerotic or acquired in the sense of.
Hey, Dr. Angelini, it's Alberto Morales. What you could do is a cardiac MRI with perfusion leg gadolinium and see if that little territory where that blocked vessel, where you would see some scar, and that would help you out there.
Exactly, and this was the idea that I proposed to the local physician, and they're going to do the gadolinium study. Very good. So this is one or two cases that I present to stimulate thinking more than document anything definite. But it is in the territory of Kawasaki arteriopathy in adults. This first case is a 66-year-old male with a history of Kawasaki arteriopathy and aneurysm diagnosed in the past. I will show you the previous movie and the current movie. He is a guy that was diagnosed only late of Kawasaki because of probable diagnosis, but he was never diagnosed at the time of the acute onset of aneurysms. He grew up in Venezuela, but now practices in Houston as a general surgeon. He was studied initially 5 years ago because of positive nuclear stress test, and he had no significant obstructive disease, as we will see in the angiogram. At that time, we saw serious aneurysm, not the worst you can see in Kawasaki, but extensive calcification and no significant stenosis. So we suggested to take warfarin and to be follow up in the future. Recently, because it continues to bleed excessively subcutaneously, hematomas from taking Coumadin, he decided with the help of a local physician to pass from Coumadin to clopidogrel, Plavix treatment. And after 8 months, he had an episode that is basically typical for an acute infarction clinically during a long intervention of 8 hours, abdominal for cancer. He had severe chest pain, and there was sort of stuttering infarction, as we are sure now after the full operation we completed. He had an EKG in the emergency room in the local hospital, and they show a ST elevation, inferior wall myocardial infarction. He was started both on nitrates and on heparin, and he was transferred emergently to our hospital for possible recanalization of the right coronary artery was suspected. He was admitted to our place something like 2 hours after the diagnosis, but the chest pain started even before. On admission, the EKG showed mild ST residual elevation, like he had already reperfused somewhat. Next. He was comfortable and had no more chest pain. So this is the few pictures that we want to use to introduce the moving pictures that we'll show later on. Basically, significant aneurysm, but not of the worst kind, in the range of 5 to 6 in the worst, with some element of stenosis, probably a mural clot in the LAD. This aneurysm includes the origin of the left main, but basically nothing obstructive. This is in a cranial RAO that you will see in motion. This segment is where I think I can make a diagnosis of left anterior descending myocardial bridge. You will see in motion that there is a tendency for systolic invagination, or you see up there at the top in this projection that is different from the previous. There is kinking, a U-turn of the coronary artery that is from the passage of coronary muscular bridges at this level. In systole, there is mild stenosis in this projection. You see in motion the aneurysms, nothing spectacular, surely not a surgical case that is rare to indicate for coronary bypass, for aneurysms. Next. You don't need to show the picture. Go ahead. Okay, this is in another projection, but we want to show the movies. It's not necessary to show. Okay, this is the cranial PA projection for mild RAO. You see a little better at this level that there is a definite myocardial bridge. In the interest of the case and the type of discussion we would like to entertain, is that sides of coronary tree, they are intramyocardial, don't get the same tendency to develop aneurysm in a diffuse disease like in this case due to Kawasaki. We are not totally sure, but 90% sure, if not 100, that this originated as a Kawasaki. This is not the glycol type of dilatation of coronary arteries with the onset of atherosclerosis. This is definitely a primary disease with a lot of calcium, but not a lot of disease, obstructive disease of the coronary arteries, which is typical of this pathology. Let's see the next case, the next picture. This is the left anterior oblique. You see the calcium at the beginning and the coronary muscular bridge at this level with the invagination of the epicardium or the proximal LAD. Systole, there is a mild myocardial bridge, but definitely it looks like intramyocardial, intramural in the muscle. Next. This is the 5-year-old movie. We'll show you the higher risk pathology. There is a proximal normal osteal segment, or mildly dilated for the expected territory at risk for this right coronary artery. Then a large, some 6 millimeter diameter proximal diffuse aneurysmal dilatation. Down here there is a sort of diffuse disease with laminar flow, not a clear flushing of the contrast at that level. That is in part because of the slow flow at the proximal level, in part because there may be something forming at that level. But it took 5 years before this coronary artery became a problem clinically. Next. Now we go to the new movie. This is 2013, a month ago.
So I see those were 5 years old.
Right.
Dr. Angelini, do you think if he would have been left on the Coumadin, he would have probably not had a problem there?
This is one of the conclusions that I will go to. Yes, I think it is. This is a clot type of complication, not atherosclerosis stent type of complication where platelet inhibitors will be effective. This is a clot from slow flow. So the left is essentially the same. We're going to show you the next that shows it a little better. The myocardial bridge is more obvious, but basically similar. The diffuse aneurysmatic dilatation is not tremendous, is still there in the same degree. Next. In the LAO, the left coronary artery shows a similar anatomy to the 5 years before. This is the right coronary artery. And you see that at the end of the right coronary artery, there is a filling defect more than the atherosclerotic disease. There is a filling defect that goes from the posterior descending 2 to posterior descending 1. In the real movie, you'll see even better than in this version that there is a tail of the filling defect that comes to the posterior descending 1. It's like there is a worm, a long segment that is involved in a clotting phenomenon. Let me show you the next. This is again almost complete occlusion of the second part of the posterior descending circulation. Most of the posterior descending comes from the posterior descending 1 in the septal branches. The posterolateral branch goes to the obtuse marginal where there was hypokinesia by echocardiogram. Next. So we enter with the balloon, we do a pronto extraction of clots, and the flow is restart briskly, but still obviously obstructed. At this point, the fellows especially were afraid to go back with the pronto that is fairly large, and we decided to put a direct stenting. Next. So this is where we deploy the stent. Before deployment, there is a significant residual lesion. We pulled something like a 5 centimeter long by 3 clot, and it must have been an embolization from a clot forming on the wall of the right coronary artery more proximally. Next. The tail of the clot in the posterior descending one has disappeared after aspiration. Next. Huh? This is it. The next step, stenting, is a good result. We covered barely the ostium but not the bifurcation of the posterior descending, and resume anticoagulation, as he was not happy with Coumadin. We switched to the antithrombotic, but basically maintained the order to continue long-term anticoagulation with the baby aspirin, and Plavix only for the first 1 year. Next. The second case came by coincidence at the same time, and it was a movie of a patient brought from Mexico. With an acute infarction again, and this kind of aneurysms on the left coronary artery. Can we start it again? This is more to aneurysm. Is not the one they call the heart. You see here this expression. Disease. This is the catastrophe. The left ventricle, if it is a single episode or more than one episode, I don't know. But the left ventricular ejection fraction now is 30%, and is involving both the apex and the inferior wall. So it's a very serious condition that may lead eventually to a need for a transplant. But at this time, medical treatment with antithrombotic medication was ordered. Next. So the mysteries of Kawasaki were already many before, but this could be a positive mystery. And the suggestion or the provocation is that maybe the myocardial bridges are protective for a diffuse arteriopathy like Kawasaki. And to briefly summarize, as I did in an editorial circulation a year ago, Kawasaki is initially an arteritis of the child, typically between 3 and 15 years of age. It's seen even in the infant age, before 1 year of age. It is probably a non-specific reactive arteritis to many different acute events, probably mainly viral infections. It involves adventitial inflammation angiographically or histologically in the kids that should die from an acute event. The etiology is not clear, is only circumstantial, and it is difficult to know if or not there is something more than a sort of a autoimmune type of reaction to some infection, like in a myocarditis. The prognosis of this acute inflammation of the arteries is more benign if intravenous immunoglobulin are used in the early stage. The incidence of late aneurysm is 25% if we use immunoglobulin, if we don't use immunoglobulin, and 5% in kids that should be treated in the acute phase with immunoglobulin. The resulting disease is different from glyco phenomenon or dilatation of the coronary artery in the context of coronary artery disease of atherosclerotic nature that only leads to some dilatation in the initial stage of atherosclerosis to some 50%, but not as it is by definition an aneurysm 100% obstructed or dilated with respect to normal segments. In this patient, it's difficult to know what the normal expected coronary tree was supposed to be at different levels. And over the years, the evolution is related to the onset of late calcification, especially in the aneurysm, but also away from the aneurysm, also in the more narrow, diffusely narrow arteries. They are rare atherosclerotic narrowing, lipid-based, and routine angioplasty is rarely required, but thromboembolism is the main source of clinical events in this disease in the older ages. And it's related, obviously, both to a rough wall of the aneurysms with calcification that many times is exposed to the inner lumen and to slow flow at the level of the aneurysm. Next, laminar flow is mainly in the middle of the artery, but not in the aneurysm.
Let him go through this first.
The main reason to present these two cases is that first, aggressive chronic antithrombotic medication is fundamental. Antiplatelets is not enough. Second, the muscular bridges could be protected. It is not obviously this a final evidence to sell anything in a credible and documented way, but good enough as a concept is to justify further exam of our rich population. We have apparently more than 400 cases of patients studied by catheterization with the discharge diagnosis of coronary aneurysm, probable Kawasaki, in the last 10 years. So one of our fellows will do a study to see if there is any way to conclude in a continuous series of aneurysm, if or not coincidental myocardial bridges are or not significantly related to a protective effect. The thing is that the inflammatory reaction is mainly at the Picard or adventitial level. In this case, it's an acute stage. And it is possible that these patients with Kawasaki that should have an intramyocardial course of the coronary artery don't have the same exposure to the factors that promote deterioration of the media that eventually leads to aneurysm formation. And it could be that we could, in the next future, document, and I wonder if any of you would agree on joining or just be awaiting the result of our studies. Usually the incidence of myocardial bridges that you can see by angiography is something like 5% in the absence of hypertension or hypertrophic cardiomyopathy, about 25% in aortic stenosis, and in hypertrophic cardiomyopathy with hypertension 10%. So we need a large number of cases to make a conclusion about Kawasaki. But the provocation is mainly in the last sentence. Can we promote an idea that has been promoted in the past, especially by Dr. Cooley, who thought that possibly patients with diffuse atherosclerosis would be better off for their prognosis in the later years if we would do not endoatherectomy but epi-atherectomy or adventitianectomy, eliminating the adventitia. If leaving coronary artery naked can prevent atherosclerotic changes in the future. It is possible. I don't know how difficult it is to eliminate adventitia, but it is possible that as we saw in the coronary anomalies like chaos, intramural coronary arteries don't have atherosclerosis, myocardial bridges basically don't have atherosclerosis. It is possible that it is the process of atherosclerosis itself that can be stopped if we eliminate the epicardial fat, or better, the adventitia. Any thoughts about it? I think that this is the end of the presentation.
Yeah, Paolo, I think that's fascinating, and it goes. I think last time we talked about this as well. Removing the lipid, the from the epicardial fat from the arteries. I just don't know how you could do that from a practical standpoint, but it certainly are interesting observations. We had another question, which is what's the distinction between Kawasaki disease and Takayasu syndrome? I thought Takayasu involves mostly the large aorta, large vessels. Does
Right.
Takayasu also involve the coronaries?
No, rarely, but can. The question is the difference between the two, and nobody knows for sure. Kawasaki can involve also the aorta, it can involve also the subclavian arteries, the renal arteries, but nobody knows for sure what is the cause of one or the other. Probably it's all non-specific reaction to a stimulus that probably is a viral infection in the kids. Influenza kind of viruses are probably the only thing that can be related to the onset of Kawasaki in kids. Eliminating the fat is easy. Eliminating the adventitia enough is to make it adventitia free. It's more difficult to think, but it could be that there would be in the future some technique that could be generated to create this possible experiment in human. Especially, I'm thinking of the patients that come from India. All of them have very diffuse disease. They don't have aneurysms. They don't have Kawasaki. It's a different metabolic disease, probably related to triglycerides and starchy food. But they have such a diffuse disease that is really many times impossible to treat with stents or coronary bypass. It would be fascinating to experiment this in that kind of population with diffuse disease to the end of the vessels, and it would also eliminate the possibility of considering the out-in place of in-out atherosclerosis as the flow of lipids coming from outside and not from inside the vessel lumen. I think Dr. What's her name, the guy in New York, Fuster. Dr. Fuster is the one that has this idea, the atherosclerosis from out in and not from in out.
Well, but I don't, you'd have to do it before there was diffuse disease, wouldn't you, to prevent the disease? Once you've got the disease and scar tissue and calcification, I can't imagine that treating the adventitia at that point is going to help that much.
Well, it's difficult to know. First would be probably in some cases to have an indication for a bypassing one vessel but not much on the others. And it would be an experiment to see if it makes any difference for the progression of the disease.
Mm-hmm.
Because many of these patients have normal cholesterol, LDL, and they have high triglycerides and diabetes, but not necessarily an LDL-based atherosclerosis. It's so diffuse that it could inspire the idea that could be also an arthritis type of condition.
Mm-hmm. And also, just from a surgical standpoint, can you really take off the adventitia of an epicardial artery?
Well, I know we can eliminate the fat, but adventitia, I don't know. You need a special instrument, I think. I don't think a surgeon can come easily. The endothelial thickening of the media, of the intima can be endarterectomy. It has been done for a long time, but epi-endarterectomy or epi-endarterectomy has never been pursued by surgeons that I know of. To complete the announcement of interesting and unusual things. Today I gave a lecture in the neighboring hospital here at the MD Anderson, and it was on Takotsubo cardiomyopathy. And the reason why is that I heard a small presentation of an incredibly large experience of Takotsubo in a cancer hospital. This is the MD Anderson Hospital. There is thousands of patients. They have more than 400 cases of Takotsubo cardiomyopathy. They say somebody said from the cath lab that they have 1 or 2 patients every day. That's incredible. So I'm going
I've never heard of that because, I mean, you know, we have a lot of cancer patients here as well, and we don't see it there. We see it in the end-stage liver disease patients.
I think what they see is cardiomyopathy, but not necessarily Takotsubo. But I want to see if we can involve them in doing acetylcholine as a way to separate Takotsubo from cardiomyopathy is probably toxic from chemotherapy more than from the emotional reaction to the knowledge of having it.
It's not really Takotsubo.
It would be interesting. Most likely they will be interested in
There's another hospital in Houston where he is, which is a cancer hospital, large cancer hospital.
So we'll let you know if this presentation will lead to involving them in our study, multi-center study on Takotsubo cardiomyopathy. Very good. Is Eric still there? No. All right, John.
Good, Paolo. Thank you very much. That was terrific. I have a couple visiting physicians from Macedonia.
All right.
So the web seminar is going to go international and viral.
All right. Very good. Great.
All right, Dr. Angelini.
All right.
Thank you. Bye-bye.
Okay. Bye, everybody.